Welcome to the deep dive. Today, we're going to explore really one of the most significant shifts in modern breast cancer care, managing the axilla. For oncological breast surgeons like you, it's been quite a journey, hasn't it? Moving from those, well, extensive dissections towards much more refined, de-escalated approaches. Understanding this evolution is, I think, crucial for optimizing outcomes and really focusing on minimizing morbidity for our patients.
Absolutely. And our goal here today is to really distill the key evidence, look at recent trials, and give you a clear picture of where we are now and maybe where we're headed. Because while, yes, axillary status is still a critical predictor, still guides so much of our multidisciplinary strategy. We can't ignore the downsides of surgery, lymphedema, nerve pain, chronic issues. That's been the real driver, hasn't it? Pushing us towards doing less when it's safe.
All right, so maybe let's just quickly touch on the history to set the scene. Back in the 90s, it was pretty much standard practice systematic ALND, axillary lymph node dissection, largely driven by that Halstedian idea of, local regional spread being the main issue.
Hmm.
But our understanding of the biology has changed quite dramatically since then.
It really has, fundamentally. We now appreciate that breast cancer, often it's more systemic, right? The spread isn't always just stepwise through the nodes. And that understanding, coupled with wanting that crucial prognostic information without impacting quality of life so much, that's been the core reason for moving away from clearing out the whole axilla.
And the impact on patients has been huge. I mean, less lymphedema, less nerve damage, better arm mobility, less chronic pain. It's a massive difference. This really paved the way for sentinel node biopsy, SNB, as a much less invasive alternative, but still giving us key information.
Exactly. S&B was a real turning point. It let us stage the axilla accurately, figure out nodal status, especially in clinically node-negative patients, without that full morbid dissection. It was a fundamental shift, allowing us to balance oncological control with, preserving the patient's quality of life long term.
Okay, so SNB becomes the standard. Then the big question for you, the surgeon, is in that upfront setting, who can actually skip the ALND completely? We're talking mostly about those clinically node-negative patients, maybe with just limited metastases found in the sentinel nodes. What was the key evidence there?
Well, this is where trials like ACOSOG Z0011 became absolutely pivotal, really a landmark study. It looked at T1, T2, clinically node-negative patients having lumpectomy and whole breast radiation, who turned out to have one or two positive sentinel nodes. And the big finding, omitting the completion ALND was safe. The 5-year overall survival was virtually identical, 92.5% versus 91.8%. Disease-free survival, too, 83.9% versus 82.2%. No statistical difference. It really changed guidelines worldwide for breast conservation. Less surgery was just as good for those patients.
And it wasn't just Z0011 standing alone, right? There were other studies backing this up. You had IBCSG 2301 and AETRM, both showing you could safely skip ALND for micrometastases in the sentinel nodes. Again, no difference in disease-free survival. So taken together, these really cemented the idea that for minimal disease, a more conservative approach was oncologically sound.
Precisely. It built a really strong case that de-escalation wasn't just about fewer side effects, it was safe from a cancer perspective too. And then you have the SONODAR-1 trial, which interestingly looked at extending the Z0011 idea to mastectomy patients. Now that's important because mastectomy patients don't usually get that whole breast radiation that was part of 0011. SONODAR-1 suggested non-inferior survival and relapse rates even without ALND for T1-2 patients with one or two positive macrometastatic nodes undergoing mastectomy. That has big implications for deciding on radiation after mastectomy.
Right, broadening the scope. Now, besides just omitting ALND, another strategy emerged. Using axillary radiotherapy instead of more surgery. Amaris, the ERTC trial, that was a big one here, wasn't it? How did that influence things?
Amaris was incredibly important. It directly compared axillary RT versus ALND in clinically node-negative patients who had a positive SNB, and it found that RT was comparable to ALND for preventing recurrence in the axilla. This held true for both lumpectomy and mastectomy patients. But here's the crucial part for quality of life. Significantly less lymphedema with radiotherapy, only 11% compared to 23% with ALND. That's a big difference for patients. Odo-ASOR showed similar results too, and this evidence directly fed into guideline updates like NCCN. Now, guidelines suggest omitting ALND in T1, T2, clinically node-negative cases with one or two positive nodes if radiation therapy can cover that undissected axilla, especially relevant after mastectomy. It really highlights that multimodal thinking.
A very critical point for practice. Okay, let's shift gears now to the neoadjuvant setting patients getting systemic therapy before surgery. Here, the whole idea is to downstage the tumor in the breast and, importantly for this discussion, in the lymph nodes. This opens up another path for de-escalation, right? Especially if patients get a pathological complete response, a PCR, in the nodes. But doing SMB after neoadjuvant therapy wasn't straightforward initially.
No, it wasn't. There were real concerns about the false negative rate, the FNR of SMB after neoadjuvant treatment. Early studies like ECOSOG Z2071, which became Alliance, and Sentina, they reported FNRs that were, frankly, a bit too high for comfort, like 12.6% in Z2071, 14.2% in Sentina. That raises the worry, obviously, that you might miss residual disease if you rely only on SNB.
So, faced with that challenge, how did the surgical community respond? What techniques were developed to make SNB more reliable after neoadjuvant treatment?
We had to refine the technique. Several things became standard practice to drive that FNR down. Using dual tracer mapping, both blue dye and radioactive tracer, aiming to retrieve more sentinel nodes, usually 3 or more. And critically, targeting the node that was known to be positive before chemo, the one that was clipped, excising that clipped node, which we now call targeted axillary dissection, or TAD. Some even looked at using immunohistochemistry routinely on the sentinel nodes, like in the SNFNAC trial. These technical tweaks really improved confidence.
And it seems those improvements paid off in terms of outcomes. There was that meta-analysis by Mann and colleagues in 2025 that looked at this. What did it show?
Yes, the Mann meta-analysis provided some really reassuring data. It found a very low pooled axillary recurrence rate, just 2.1%, for patients who had a negative SLNB after neoadjuvant therapy and skipped the ALND. And for those who had negative targeted dissection, like MARI or TAD, the rate was even lower, about 1.5%. Perhaps most striking, the analysis found no significant benefit from doing ALND compared to just SLNB in patients who achieved a nodal PCR. The risk ratio actually favored SLNB. This translates to excellent 5-year outcomes: 87% disease-free survival, 90% distant disease-free, and 92% overall survival with just SLNB in those achieving nodal PCR. That's strong support for de-escalation in this setting.
Those are really impressive numbers. So the next logical step is figuring out how to predict who is most likely to get that nodal PCR, especially in specific subtypes, HER2 positive disease, for example. That Hamdi et al. Study from 2025 looked into predictors there. What did they find?
Right. Predicting response is key for selection. The Hamdi study identified a few significant factors for nodal PCR in HER2 positive patients after neoadjuvant therapy. Things like strong HER2 positivity, a +3 score, getting dual anti-HAH therapy trastuzumab plus pertuzumab, being clinically node negative before starting chemo, and also if the primary tumor itself had a complete clinical response. These factors help us identify patients more likely to benefit from de-escalation.
What about imaging after treatment? Do they find anything useful about, say, ultrasound findings post-NAT?
Interestingly, in their cohort, they found that all the T1 tumors ended up node negative after treatment, though that specific point wasn't statistically significant on its own. But what was significant and quite encouraging was that if the lymph nodes looked negative on imaging after neoadjuvant therapy, they were indeed pathologically negative, a 100% negative predictive value in their group, which, hints at the potential future for maybe even avoiding surgery altogether in some highly selected cases based on imaging response.
Very promising indeed. And the research is definitely not standing still. There are ongoing trials pushing this even further, right? Exploring alternatives to ALND, even if there is residual disease after neoadjuvant therapy.
Exactly. Trials like Alliance AA011202, ADARNAT, and NSAB B51R2G3304 are asking really important questions. Can regional nodal irradiation, RNI, effectively replace ALND for patients with some remaining nodal disease after chemo? Or conversely, if a patient converts to node negative, YPN0, can we safely omit RNI altogether? It's all about finding that sweet spot, minimizing treatment while maximizing safety.
Which leads us nicely to maybe the ultimate form of de-escalation. Completely omitting any axillary surgery, it sounds radical maybe. But the idea is to push morbidity reduction even further for very select patients early stage, clinically node negative. What's the evidence base for that?
Well, the SOUND trial really brought this into focus. It was a phase 3 trial looking at patients with small tumors up to 2 centimeters and a negative axillary ultrasound before surgery. So CT1 and 0, US negative, having breast conservation. And the quite remarkable finding was that omitting all axillary surgery was non-inferior to doing SNB when it came to 5-year distant disease-free survival. That was a major finding.
Wow. And was SOUND an outlier, or did other studies find similar things?
The Encima trial pointed in a similar direction. It showed that for early stage T1 to an N0 patients, less expensive axillary surgery resulted in non-inferior 5-year invasive disease-free survival. What both these trials really underscore is how critical accurate patient selection is before surgery, relying on good imaging, good clinical assessment to identify those truly low-risk patients who might not need any axillary intervention.
But it's crucial to stress this isn't for everyone, right? Are there specific groups where omitting SNV has more solid data behind it currently?
Absolutely. Patient selection is paramount here. We do have some prospective data supporting SNB omission in certain groups, like older patients with strongly ER positive, HER2 negative cancers, for example. And more research is ongoing. Trials like BOOG 1308, SOPET, Nautilus, they're all still looking into the safety of omitting SNB in potentially broader populations. So watch this space.
Okay, so we focused heavily on surgery, but de-escalation isn't just about the scalpel. How do radiotherapy and systemic therapies fit into this picture? Regional nodal irradiation, RNI, for instance, it still has a role, especially for higher risk node-negative patients, based on trials like MA20 and EORTC 22922 showing outcome benefits.
Yes, definitely. Though there's still that ongoing discussion about which nodes to include routinely in RNI, particularly the internal mammary nodes. You have to balance the potential benefit against the risks of toxicity to the heart and lungs. It's a very nuanced decision, often depending on tumor location and other risk factors. Needs that multidisciplinary input.
And things get even more complex when we think about sequencing radiation with all the newer systemic agents, checkpoint inhibitors, CDK46 inhibitors, ADCs. How do you navigate that?
It requires really careful planning and timing. For example, the current advice is often to hold CDK46 inhibitors during radiation because of potential overlap in toxicities, especially hematologic ones. And remember, the axillary status itself still influences systemic therapy choices, like recommending CDK46 inhibitors for higher risk, node positive, hormone receptor positive disease. Everything is interconnected.
Finally, what about de-escalating systemic therapy itself using biomarkers? How does that fit into this personalized approach, even when nodes are involved?
This is another huge area of progress. Using gene expression profiles like Oncotype DX or MammaPrint, or looking at Ki67 changes after short-term endocrine therapy. These tools are helping us identify patients, particularly with hormone receptor positive, HER2 negative cancer, who may not benefit from chemotherapy even if they have limited node involvement. It's moving towards truly personalized treatment, tailoring not just the surgery or radiation, but the systemic therapy based on the tumor's biology.
So let's try to bring this all together. As we wrap up this deep dive, what's the big picture takeaway for you, the oncological breast surgeon listening today? We've traced this amazing path of de-escalation and axillary management, all backed by solid trials and a much better grasp of the biology.
I think the key takeaway is that decision making is more nuanced than ever. De escalation offers huge benefits for patients, less morbidity, better quality of life, that's undeniable. But deciding on the right axillary approach for each individual patient remains complex. It absolutely demands that multidisciplinary team approach. You have to weigh all the factors: clinical stage, pathology, biology, patient factors, and consider how surgery, radiation, and systemic therapy all interact.
And the trend seems set to continue, doesn't it?
Yeah.
It
Yeah.
feels likely that ALND will become even less common as our diagnostics improve and we gather more data from ongoing trials. Constant reevaluation of guidelines, staying updated on new evidence, it's essential for refining these personalized strategies.
Absolutely. Which leads to perhaps a final thought for you to consider. As we keep moving towards less invasive but just as effective treatments, how do we as a surgical community adapt? How do we ensure our training, our practice models evolve so that every patient gets the most appropriate, most de escalated care possible, all while maintaining oncologic safety and prioritizing that all important quality of life? That's the challenge and the opportunity ahead. Something to reflect on after this deep dive.